Good morning, everybody. I now appreciate that I've got a productivity challenge with this presentation, so I don't have time to talk to you about my worst presentation, but it was in Whaley Bridge and it did involve the Women's Institute, but I won't go there. I've only got 83 slides, so I'll take a whistle-stop tour through them. I'll try and incorporate some of the themes that have been spoken about at a very high level that Mike, Julian and Anita have discussed. I'll talk about some of the low-hanging fruit that Mike mentioned, some of the change parameters and considerations that certainly we as a private sector organisation would consider and hopefully bring to the NHS, and also the huge pressure on cost improvement programmes which seems set to go on to 2061. I'm really worried about my self-assessment fruit machine lottery in 2061 now, and what that's going to come in the outturn. And I think hopefully as a result of that there's some practical facts and discussion points in this that will come through, and I appreciate that it's probably a more narrow focus than some of the discussions, but nonetheless I think some of the stuff that happened is eminently transferable between all sectors. But I'll talk about the sexy and rock and roll world of pharmacy to you, so please try and stay awake. In case you're any doubt aware the challenges, and you know, it's always worrying to see that the US spends 18%, 17% of their GDP on healthcare in its entirety. The flip side of that is they waste $500 billion of their spend on procedures that are just not necessary, drugs that are not used and prescribed. And that's a massive problem for them. It's also a massive problem for us as well. We spend 11% of the NHS budget on drugs, and that doesn't include cost of service. And about 50% of the patients that receive those drugs don't actually take them in any case. So if you want to look at an area where you can make gains in productivity, you can make gains in cost efficiency, then I'm championing a bit for you to support and have a look and invest in pharmacy through this presentation. And my presentation is going to be around case study. It's going to be a live example of what we did and how we did it. So it's not just about the concepts of change and how we might need to reorganise healthcare, but also the practical ways in which we might want to do that. And this was done in partnership. You usually have somebody from Plymouth Hospital stood here next to me, so unfortunately you haven't got that today. Simon is a much better speaker than I am, so hopefully you'll bear with me. Why do this? And its concept is providing better outpatient pharmacy services in a hospital, and there's a number of reasons why we want to do that. Outpatients themselves, and if you've ever been an outpatient and waited for a prescription, you probably know it's intensely frustrating and you might have waited an awful long time. What it actually does for the inpatient pharmacy services is create a lot of hassle, a lot of noise, a lot of operational challenge for them as well. So not only is it a pretty difficult service to provide, it also has a halo impact on the inpatient services as well. So Simon and his team, Director of Pharmacy and his team, brought us in to manage the outpatient pharmacy services. There are some efficiencies we can make around VAT as well, which we'll talk about, but also improve the inpatient service as well. So a lot of financial benefits of doing this around retaining some control about on-site dispensing of prescriptions that used to be prescribed on FP10s. Patients would take them and probably do what was discussed earlier and throw them away or not use them. And also then access to the procurement that the NHS has in secondary care as well. And I would say as well, you know, there is a challenge around capital and use of private sector capital as investment, both in the estates and also in resource as well, can be driven through this. So the NHS doesn't have to find the money is out there. And this is about the conference is narrow in so much as it's around the last part of that, but obviously the QIP agenda is really important to us as well. So what we're doing here was new, it was novel, it improved the quality of the service for patients, not just only in how long they have to wait, but also how they receive the service and the amount of counselling they'd also get when they get their medications, hopefully to reduce the 50% of patients that don't actually take the meds in the way they're supposed to. The key drivers for us, obviously, the private sector organisation, we're trying to deal with the chaos, I suppose, that's going on within the NHS at the moment, and how we can play a part in supporting some of the real key boundary changes that need to happen between primary and secondary care, but also within secondary care in itself. One of the things that we all talk about is the principles of change, principles of redefining that, but at the very centre of this is how we commission services and also what we want to commission in the way that the services would be there. Everything that underpins that is people. And we went through a competitive dialogue process with Plymouth. And one of the recommendations I'd make is when you're commissioning a service, particularly if you're going to work with them in partnership, that you really consider doing something like that, because ultimately you have to be able to work with the people, you have to create a partnership, and tendering and commissioning services just as a paper exercise seems to me to be crazy. But it takes a little bit longer, so you have to consider that when you're doing something. The implementation of the service, lots of sort of data on there. I think what we wanted to do is do it properly and then accelerate, rather than, I think what sometimes happens is just go as quickly as you can and it falls over and you have to unpick it, and that's got a huge cost and a huge waste to it. The benefit of doing that, of accelerating, means that you can bring on those savings sooner. I think in that the lessons learned from the implementation of this project and what we wanted to get out of it is that it is about how you work with your people, how you engage your people is a very important point. I know that you all know this, but actually it takes discipline, it takes effort, it takes time, it takes commitment, but it also takes the right measurements and the right data gathering, so you have to make sure you have that in place at the start. And you also have to You have to think about how you're going to deal with things when they go wrong, because it's very easy to say that's the private sector, it's their fault because they're nasty and they're the devil. But in reality, these things will happen, and they happen internally. So having those conversations as you're beginning a program makes it much easier to deal with those when they do happen, because any change process will come across barriers and come across new challenges that couldn't be anticipated at the start. I've spoke to you about the approach to Go Live, how we did that, and as I say, we wanted to start off and get it right and then accelerate, rather than just sort of drive into it in a big headwind. Governance arrangements are very important, and but they have to be governance arrangements for the right reasons, and governance arrangements that monitor the right things. And the Francis report talks a lot about this, so I won't go on about it too much, but you have to make sure you have the right mechanics to review it properly and review it for the right reasons. And often some of the pathologies we have around reporting or around the actual measure itself, which Francis talks about, not about how you change it or what support structures you have in place to make a difference within that. Financial for the trust, the arrangements around adhering to formularies, making sure that patients are getting the right things in the right way, something that's been signed off by the medical directors, director of pharmacy, but also the duration of supply, so there isn't a profligate supply of meds that aren't required, and that's often a tendency, particularly around secondary care. There's some retail income as well that the trust can benefit from, and also as a private sector organisation, I do feel we're much better at collecting prescription fee income. I know it's not an awful lot, but those pennies do add up because they get reinvested back into the hospital. What we're also very conscious of in pharmacy, it's not perhaps the sexiest part of the NHS, but actually it's probably your last experience of the NHS, particularly if you're in a secondary care. And we can affect your view of the NHS if we get it wrong, and you'll all know that if you've been sat waiting for 2 hours for a script for antibiotics when you've got a screaming child. Derriford were a high-performing trust, and probably Mike spoke about actually the ones that can get the quality right as well. So they had got a very good turnaround in time. But again, bringing us in to help focus the service on an outpatient can reduce that waiting time by 33%. In some of the worst performing trusts where we see those waiting times go from 2 hours down to 10 minutes, and that's obviously a huge benefit for the patient. This graph sort of just shows really, I tried to get some sexy graphs, but you sort of usurped me with that. So this basically shows that the more work is done on site and patients get access to their meds quicker, rather than being given potentially an FP10 or having to wait a long time, they get their prescriptions when they need it, so they can start treatment on the day it was intended rather than leaving it to lag. And again, that's problematic in terms of waste. So the sooner you start, the sooner patients start taking it, the more likely they are to retain those good messages that both the doctor and the pharmacist would have given them. And again, that's just some of the data around that, but also it's about how we interact as clinicians, and I'm a clinician myself, with the patients, how we talk to the patients, how we reinforce some of the messages that are given right across the value chain within the NHS. This on the productivity side for Derriford, we were focused on the outpatients, but on the inpatient side, what this graph essentially shows you is that they're able to do their inpatient work a lot quicker and in a lot more productive way, and also spending less money. And I think where we've worked with other trusts, and we've got a case study on Liverpool on the back, they've seen a 33% improvement in their productivity on the inpatient side because they've removed the distraction of the outpatient workload as well. A little bit of a story on this one around investing for the long term. I know that's sometimes difficult, but some of the decisions that were made during implementation of the rollout of the service meant that we wouldn't quite hit the savings plan in year 1, but because of that in year 2 we were able to outperform our savings target by some significant amount. And these aren't my figures, these are figures from Plymouth themselves. So a £400,000 overachievement in year 2 seems to me a good investment to miss the budget by about 30,000 in year 1. What's made this a success? I think it's also to do with how we've worked together, and that's around people as much as anything else from an organisational point of view. But it does take effort, and it does take an investment in the people that are doing this to make it want to work. And it's not always easy. We do make mistakes on both sides, and I think you have to be honest with one another, and you have to have those conversations sooner rather than later. KPIs and continuous monitoring and continuous improvement are an important part of that process, but any of the things like Denning Lean, Six Sigma, they're all, from a theory perspective, very sensible and very logical, but actually it's people that implement those, it's people that make the difference, and it's people that have to work together. So we as leaders within this have to put the constraints and infrastructure to allow that to happen and allow those individuals to make the best use of that. But it is hard, and it does take a lot of energy. I think just looking towards the future, and then I'll sort of wrap up for the question and answer session. I think we have a responsibility, and certainly from Lloyds Pharmacy, to try and improve the patient's experience moving from secondary and primary care. And I think it should be less about silos, but more about how do we integrate people back into primary care better, and what does that journey look like, because it does often fall down. We have some, again, problems around systems, IT, transfer of data, transfer of knowledge, the consistency of message to and fro. And I think what we can do as the last point perhaps in that cycle is help improve that. But again, it takes willing partners, not just in healthcare, but in social care as well. And there'll be various people in this room, will be stakeholders within that. I think there are issues around long-term condition management that we can look at, and efficiencies from there. But I think what this project shows is where there's a will, there's a way, and there's a desire to make improvements. And that not only benefits the health economy, but it also delivers better quality, and it gives a better service to patients. So all of the stuff that Mike spoke about on the start, that there shouldn't be a dissonance between quality and cost. Actually, if you get this stuff right, it can work, and it's not just a sort of a blithe concept that we all find struggle to implement. So I'll leave it there because I know we're overrunning, but thank you.